Good afternoon, everybody. Thank you very much for the introduction. I'm a neurologist from Amsterdam, Can
you speak up, please? Use your microphone.
Is this better?
Yeah.
Thank you. Okay. Well, in Amsterdam, we follow quite a lot of patients with X-ALD. We are the National Reference Center, and we do have some experience with this disorder. And I was asked to elaborate on 3 subjects, and I have only 15 minutes, so I'll make it a very concise synopsis. But the subjects I've been asked to speak on are women with ALD, the long-term outcome after bone marrow transplant, and something about the newborn screening implementation in the Netherlands. So the first subject, women with ALD. Well, first, of course, ALD, the disease has been known for a very long time, and the disease in men is reasonably well characterized. You've heard a lot about it today. Most of you have a lot of experience with the disorder, but basically it's a very heterogeneous disease that affects the adrenal glands, that affects the spinal cord, what we call AMN, and some people develop those inflammatory cerebral lesions. And what has been known is that we cannot predict who gets which symptoms and how the disease progresses. And even within the same family, as this kindred aims to illustrate, with the same mutation you can have all kinds of different disease mutations. And the women were always the group that was kind of neglected. I mean, everybody knew basically that they would get symptoms, but of course, and also for those women themselves, usually all the attention was focused on their sons with cerebral ALD or their adult brothers with more severe complaints. So to briefly summarize how we think that the natural history of this disease is as follows. In contrast to many other inborn errors of metabolism, you're born completely healthy. It's been mentioned today, before the age of 3 years, roughly, it's very unusual to have any symptoms. So they're normal babies, normal toddlers. And basically, I think it's fair, most people think that it's fair to consider ALD as a progressive neurodegenerative disease. And what usually happens first, but not always, you get adrenal insufficiency, and the older you get, the higher the probability that you also get the spinal cord disease with the incontinence and the gait disorder, which gradually worsens over time. And we think that virtually all men with ALD eventually develop that spinal cord disease, and most develop adrenal insufficiency, as long as you get old enough, if you get old enough to develop the symptoms. And then a proportion of men will develop the cerebral ALD, either in childhood, but as Patrick Aubour said, also very often in adulthood. So this is probably how you should look at this disease. So where do the women fit in? Because X-linked disorder, women have 2 X chromosomes, men only 1. And mostly they're considered carriers, but carrier implies that you only have a genetic mutation, but that it does not cause any problems. Well, if you look at the biochemistry, let's look at C26, the very long chain fatty acid that is grossly increased in ALD and that we use for the diagnosis. The green dots here are people without ALD, the blue dots are men with ALD, and you see that all men with ALD have abnormal plasma C26. The women are intermediate. There are a few who have normal levels, but most have abnormal levels. So biochemically, there's also something going on. So that is the first clue that they might be more than just carriers. Well, we didn't do anything new. I mean, even in the 1980s, Moser already described that women can have symptoms. But what we did do, we looked at a very large group of women who came to our clinic, or mothers, sisters from patients who came to our clinic, and we systematically examined them to see what kind of complaints they had. And it turned out that actually most women did have very clear symptoms of spinal cord disease. Many women had a gait disorder, just like the men, and many of them also had very prominent incontinence and also fecal incontinence, something that you hear less from the men. And what was particularly striking is that young women under 40 were usually not symptomatic. They usually did not have any signs or symptoms that we could attribute to ALD. But once they became older, over 40, and especially over 60, you could see that most women, well, roughly 80% or more, really had specific complaints that you could really localize in the spinal cord, so that you could consider as caused by ALD. So there are two things that we can learn from that. Like the men, the older you get, the higher the probability that you have symptoms. And also, it is not fair to say that women are carriers. Women with ALD have ALD. It just manifests a little bit different. Well, I was going to say today that the adrenal insufficiency, that it actually doesn't occur in women. At least we never found a woman who had adrenal failure. But just because before this presentation I was introduced to a woman with ALD who was recently diagnosed with adrenal failure. And I do have to admit that in all the women we saw, we did not do the stimulation test for all of them. So that is maybe something that I think Florian told me in the past. It probably does occur. It's very rare, but a few percent might be affected. And well, why not? Well, we briefly, this is not very interesting because this failed. Of course, we wanted to know why are some women symptomatic and others not. And I'll just skip over it because we don't know. Another thing I was asked to comment on is about the bone marrow transplant, because actually that was also already discussed extensively today. The bone marrow transplant works for cerebral ALD. If you do a timely transplant, the cerebral disease stabilizes, and that part of the disease is treated. But we and others also, we of course, if you follow people for a very long time, then you start to notice things. And in our cohort, we knew a few adult men, 5 adult men, who were transplanted in early childhood for cerebral ALD, and we did notice that in their 20s they started to develop subtle signs of myelopathy. And of course this suggests that the bone marrow transplant probably does not work on the progressive spinal cord disease, or well, maybe that is too strong, can't actually prove it doesn't work, but at least it shows that it does not completely prevent myelopathy. If it delays the onset or slows the progression, is something that is going to be studied now. The bone marrow transplant people are now very motivated to show that it does affect the spinal cord disease, so we'll see. But at least it shows that it's very good that there is still a lot of work on other treatments, because the spinal cord disease is the big problem for most people, and we simply do not have any effective treatments yet. Well, the last thing that I'm going to briefly discuss is newborn screening. Of course, the Americans already you heard about it this morning. It is implemented already in parts of the United States. And well, technically it is feasible. A few years ago, there were people who demonstrated that you can diagnose adrenoleukodystrophy, that you can diagnose it with a biomarker in dried blood spots. And the test that has been developed to test for a certain kind of very long chain fatty acid is easy, it's cheap, and it's highly reliable. So you have the test. But then the big question is, do you use the test? Do you screen or don't you screen? And well, as a speaker late in this afternoon, you already know everything. I think everybody convinced you that there is a health benefit for male neonates. I mean, usually when you are unfortunate enough to be the first male in your family with adrenoleukodystrophy, you often get diagnosed too late to benefit from bone marrow transplant. Or you get adrenal failure and you're only picked up after the 9th hospitalization. And so for male neonates, there's a clear benefit. You can get good follow-up and you can get timely treatment. So for males, I think most people would agree, absolutely, screen. What are the problems? Well, the problems are that you pick up other diseases. You also pick up other paroxysomal disorders. There's other diseases that are diagnosed by increased very long-chain fatty acids, for instance, Zellweger spectrum, and those diseases are not really treatable. And of course, you know that the agencies that deal with implementing newborn screening, they are not too keen on diagnosing diseases that have horrible consequences for people and for which you have no treatment to offer. That is not considered ethical. So that would be a drawback, that you would pick up other disorders. Well, the biggest problem is, as you saw, I'm going to make everybody dizzy by clicking back very quickly. See, many women with ALD also have biochemical abnormalities. So with this test, you're going to pick up all, or at least a large proportion of women with ALD. And the thing is, well, women, you could argue that there's no clear health benefit if you pick them up early. Because, well, my story got more complicated because maybe they do develop adrenal failure, but anyway, that is probably a rare thing, and at least, like Patrick said, they don't develop cerebral ALD. So you have less clear reasons to identify them. You could say that it's a burden to identify somebody and say, well, over 40, you're going to have more than 80% chance that you won't walk so well, but there's nothing we can do to prevent it. So in the Netherlands, weighing all these factors, they came to a slightly different conclusion than they did in some states in the United States. And that is what you will get. Each country will, there are slight cultural differences, so everybody will weigh those factors slightly differently. And in the Netherlands, it was chosen to screen boys only. And I think that, well, theoretically, that is a very rational choice, a very rational thing to do. The only problem is that it's going to be practically almost impossible to do that, because it would be the first disease for which there would be a difference in screening between male and female neonates, and that is why it's been on hold now for more than a year, because nobody knows how to implement this. If you get a card with a name on it, it's often not clear whether it's a boy or a girl. So that would mean that the cards would have to be redesigned, the workflows would have been changed. So it's unclear how this is going to be resolved. It could be that they say, okay, then we're not going to screen, or they're going to or follow the American example and screen everybody, which I think is unlikely. Or, well, we'll see. So, I'm going to skip this. What I would like to say that what I would like to what Florian said, there's a lot of new treatments on the horizon. There are a lot of new potential options, but it's very important that we work on trial readiness, so that we learn to understand how this disease develops quantitatively, so that when there are new treatments, that we are able to evaluate in clinical trials if they are effective or not. And therefore, I would like to come back to what the previous presenter said, Wolfgang. I feel compelled to say something about that. See, everybody is entitled to his or her own opinion, of course. But I would like to emphasize that Lorenzo's oil, the diet on Lorenzo's oil is not pleasant. It has side effects and it does impact your quality of life. There is no really solid evidence that it does anything. So I think if you choose to use Lorenzo's oil, then you can weigh for yourself, for your own situation, whether you want to try that. But I don't think it is something that you should do lightly. That is something that you should really consider, and really there is no solid evidence, because there is not a single clinical trial that really demonstrates that it works. And the problem with Lorenzo's oil is, of course, that it was introduced into clinical practice really quickly. Everybody was enthusiastic because there's a biochemical effect. And therefore, now you are in a situation that you kind of have to prove that it doesn't work. And to prove that something doesn't work is very complicated. And so I think what we can learn from that is that with new treatments in the future, that we should follow really that we should resist the urge to just implement something, that we should do careful clinical trials, and that we should work the next few years on really delineating the natural history. Thanks. I hope I stayed within my 15 minutes.
I think you did.